I'm glad to have this chance. I want to give you a little forewarning that I made these slides myself. I flunked the PowerPoint course, and so the backgrounds are wildly different. My new technique is to draw a slide and take a picture and then put it on my presentation. So I hope you give me some latitude on the slides. This particular slide, I gave a speech last week to an association that works with geospatial information systems, and I wanted them to know that I really understood their topic. And this is a map I drew when I was 10, right after my father read me Treasure Island, and you can see that there's a lot of geospatial information on this map. You can see there's a safe harbor on the south, and that there's a fort, an old fort up in the northwest, and some mountains down in the southeast, and of course we know there's treasure buried under all those X's. And while I was explaining this slide, one of these guys takes out his smartphone and checks something and puts his hand up and says, just check the latitude and longitude of your island there, and it's somewhere in North Carolina. So be forewarned. When I first started practicing medicine in Roseburg in 1974, one of the things that I remembered the most about those early years was how incredibly vulnerable the people were that came to see me. 1974. These are folks who had something wrong with them, that they were afraid, they were worried, they were anxious, they didn't understand what was happening, and they had come to me for help. And they'd put their trust, and in many cases, their lives in my hands. And that seemed like a pretty sobering responsibility for a 27-year-old just 4 months out of his internship. And I wanted to help them, of course. I think all practitioners want to help the people that come to them. And I did everything I possibly could, used everything at my disposal, used all the technology I could get my hands on. Cost was never a consideration to me. And even then, there were times when I failed. And there was this almost ritual acknowledgement of failure in those first few years of my practice, where you had to walk across the hall. I called it walking across the hall. And the hall was this hall between the big double doors that go into the emergency room with all the trauma bays and the green curtain rooms, and this other room on the other side that had a sofa and some chairs, and that's where the families of people who had been brought in by ambulance waited. And on those instances when we weren't able to save someone's life from a cardiac arrest or trauma or a drowning, then I would have to walk across the hall and tell the family that their husband or wife or daughter or son was dead. And that wasn't anything that we were able to do about it. And, notwithstanding what President Trump said about no one knew that healthcare could be so complicated, it's actually not very complicated. At its essence, it's a very, very personal experience that affects one person at a time and the people that love them. And that was reinforced to me when I had to walk across the hall. And, it was a ritual that I hated. It felt like a long, hopeless, helpless journey to walk 20 feet across a tiled floor to tell people who had come in for help from the medical system that we hadn't been able to save their lives. And I think one of the problems that we have today in Washington, D.C. is that human element is totally missing from the national health care debate. It has been for so long. This is a debate that's been very narrowly framed about, in a very partisan way, about who will retain or lose coverage, the relative cost of the Affordable Care Act versus the Republicans' alternative, and of course, the political consequences of doing anything in the midterm elections. And uncertainty abounds because of those circumstances. Uncertainty about whether or not the ACA will be repealed, and if so, what it will be replaced by. Uncertainty about the stability of the insurance market, and uncertainty for the 20 million Americans who gain coverage under the Affordable Care Act, and millions of other people who are living literally one illness away from bankruptcy. And it seems to me that those issues, those set of issues, and those people are going to continue to live in uncertainty, regardless of which party prevails, unless we begin to put that human element back into the debate that we're having and try to be very, very clear about what it is we're actually trying to accomplish. And while both Republicans and Democrats are basically trying to figure out how to finance and deliver medical care, in my view, the real issue is health. Because health care is not necessarily synonymous with health care. Health care is a means to an end, not an end in itself, and it doesn't have any intrinsic value outside its relationship to a health outcome except as an economic commodity. And furthermore, I'm all sure you've seen some version of this slide at one point or another. Most of the things that affect your lifetime health status have very, very little to do with our formal medical system. They have to do with socioeconomic factors and behavioral and lifestyle choices and environmental factors. And this becomes very, very clear if you look at the United States compared to the OECD nations. This first slide shows the percentage of the GDP that we commit to healthcare, and you can see that the United States is really an outlier at north of 19% now, whereas the OECD nations are around 10%. And then if you look at the combination of spending on medicine and social investments, you'll see that the US is about on a par with the OECD nations, but we spend much larger share of that on medicine rather than social investments, which is just the opposite of those other nations. And this final slide demonstrates the ratio of medical spending to social and community investment. And again, the United States is an outlier. But these countries have far better population health statistics than the United States. And so why do we continue to invest in medicine over social investments? Why do we tolerate this growing discrepancy between community investments and investment in our healthcare system, in spite of the fact that we know that that's not getting us the outcome that we want? And again, I think the answer lies in that human element. It lies in the intersection between human mortality, which occurs one person at a time, and modern medical technology. And to illustrate that, I want to tell you a short story about a rafting trip I took a friend from New York City, down the Rogue River in 2005. And this was someone who lived in New York City and had never had that kind of an experience before. And it was August, and the salmon were spawning. There were a lot of fish on the banks and fish swimming up the river. And one day we drift past this magnificent male Chinook salmon, maybe 35, 40 pounds, and he's still heading upstream, but he's struggling against the current and against his fading strength. And I'm sure you've seen some of these big fall spawners. He's just all beat up. He's got scars on his sides and fungus growing on his body, and his fins are all tattered and torn, and he's way downstream from the spawning grounds. He's probably never going to make it. But in dying, he's going to give his body to the river and provide the nutrients that are required to sustain the next generation. And I've always thought that the life cycle of a salmon was a lovely metaphor, not only for the relationship between life and death, but also for the responsibility that each generation has to the next. But my friend just looks at the salmon and then looks at me and says, "Oh my God, what's wrong with that fish?" And without even thinking, I said, "Well, there's nothing wrong with him. He's just dying." Now, you don't hear that very often in the halls of medicine. Well, there's nothing really wrong with you, you're just dying, right? And that's because our society doesn't view death as a natural part of the life process. We view it as something abnormal, something alien. We view it as a failure, right? Walking across the hall. And because of that, we've developed this almost unlimited array of diagnostic and therapeutic interventions with which we treat disease and disability and try to stave off the inevitable consequences of aging. And that's resulted in this huge and very profitable industry that is devoted not just to developing new technologies, but to financing and delivering them for the benefit of individuals. And if you view this arrangement from an individual standpoint, these technologies are miraculous. They do amazing things, right? But there's a darker side if you look at it from a societal standpoint, because there wouldn't be a problem if all of these people could pay the cost of their own health care themselves. But that's clearly not the case. In 2017, we increasingly rely on public resources to finance the cost of care for individuals. So we've created a system that provides unlimited benefit or services one individual at a time while requiring public resources to finance that cost. That's the classic tragedy of the commons that Garrett Hardin described in 1968. So the point I want you to take away here is that what is at contention in the United States healthcare debate is the allocation of public resources and who benefits from that allocation. One of my favorite quotes is from a guy named Thomas Pynchon in a novel. He's an American novelist, and his novel is called Gravity's Rainbow. And he said, if they can keep you asking the wrong questions, they don't have to worry about the answers. And the problem with the healthcare debate today is that they are asking the wrong problems and they're solving for the wrong problem. Did it ever occur to you that healthcare is the only economic sector that produces goods and services that none of its customers can afford, but all of which will need at some point, often as a matter of life and death, at which point cost becomes totally irrelevant to the individual seeking care or the provider providing care? So the only way a system like that works, a market works in that kind of a system, is if it's heavily subsidized. And so at its heart, the national health care debate is a partisan debate over who should be eligible for a public subsidy and how much that subsidy should be. And here's the interesting thing. If, as President Trump said, nobody knew that health care could be so complicated, also then nobody knew that Republicans and Democrats could actually agree on so much, because there is a broad area of agreement between the Affordable Care Act and the bill that the Republicans tried to pass out of the House, although you'd never know it, given the way that this dogfight is being covered in the media. First of all, both Republicans and Democrats recognize, you like that? That's one of my favorite slides. They get more colorful as the night went on and I had a little more bourbon. They all agreed that, first of all, because healthcare costs too much, all of us need some third-party payer to help us foot the bill, right? And that can be either Medicaid, publicly financed healthcare, or it can be private commercial care, right? So they agree on that. Secondly, they agree that there is a role for Medicaid to cover adults who don't fit into the original Medicaid categories: pregnant women and children, the elderly, people who are blind or disabled. So there's an agreement on that. And third, there's agreement that low-income people who aren't eligible for Medicaid still need some subsidy in order to purchase private insurance. So let's start with that common base of agreement. That means there's then three areas in which they disagree. The first area of disagreement is, what should the income eligibility level for Medicaid be? And you know, the Obamacare has it at 138%, and the Republicans want it at 133%. But here's the thing. The issue of whether Medicaid should be expanded to working adults who are not in one of the original categories is a huge policy shift that's occurred since 1965. And I think people should recognize how significant that is. So the argument isn't whether we should expand Medicaid, it's how much we should expand Medicaid. Then the second area of disagreement is the nature of the subsidy that will be provided to people who aren't on Medicaid. And the Democrats wanted to do that through a sliding scale, declining a subsidy through the exchange, and the Republicans want to do it through just a tax credit, which of course is another form of public subsidy. And it's interesting that this area of subsidizing people who aren't on Medicaid is the major point of contention with the Republicans. When you hear them talking about the fact that the ACA is failing, they're talking about rising deductibles and premiums, most of them in the individual market, which was going on, you know, in 2005, and it was only about 7 or 8% of those who were covered. And then the third area of disagreement has to do with cost, right? How much should the states pay and how much should the federal government pay? And then how do we control the overall cost of the Medicaid program? So the Republicans, as I'm sure you've been discussing, have proposed block grants that are calculated off a base year and then don't grow any faster than the medical component of the CPI. So although they are having a conversation about costs, they're not talking about system costs, right? They're not talking about the cost of the goods and services that we're buying. They're simply talking about who's going to pay the bill. So this isn't an ideologic debate. It is a blind spot, because the bill ultimately is unaffordable for individuals seeking care, but also for the state and federal governments who are providing the subsidies. So as I said earlier, I think both Republicans and Democrats are asking the wrong question. They are solving to make health insurance more affordable instead of solving to make health care more affordable, which is actually what's driving up the cost of health insurance in the first place. So as long as they assume that cost is fixed, right, that we can't do anything about it, we just got to pay the bill, then the solution space becomes limited to just three variables. One is eligibility, which is really the debate about who should be eligible for Medicaid. One is benefits, and that was the fight with the Freedom Caucus, wanted to reduce the basic benefits under the Affordable Care Act. And the third one is simply cost shifting to individuals, or cutting provider reimbursement rates, or increasing co-payments and deductibles. And of course, none of those things solve the cost. They shift the cost, but they don't reduce the cost, because people who don't have care fall into that coverage gap. They go to the ER, where federal law requires that they be seen and treated, and those costs are simply shifted back to those who can pay, repeating the cycle. So instead of asking, how should we reduce the cost of health insurance, the real question is, how should we keep Americans healthy? And part of that answer is reducing the cost of health insurance. So by solving for health, then the solution space becomes a lot bigger, Because not only do you have those traditional three variables, you can begin to look at and have a conversation about the cost of the goods and services that you're actually purchasing. And that, I think, gives us an insight into the two steps that need to be taken to actually resolve this issue. The first one is reducing the rate of medical inflation to a growth rate slower than that of public revenues. And then the second one is figuring out how to begin to reallocate resources from the medical budget upstream in the community to actually begin to address the social determinants of health, which have a profound impact on the overall health of the population. Now, Oregon's had some experience in that first point, trying to reduce the rate of growth of medicine through our coordinated care organizations. And I'll give you just a real brief synopsis of the CCOs. So they were formed out of the scarcity of the Great Recession. And one of the reasons it's so hard to reform the healthcare system is that we keep paying for it. As long as we keep funding the status quo, there's absolutely no incentive to change. But in 2011, in Oregon, an incentive arrived in the form of a $1.2 billion revenue shortfall in the Medicaid budget. And if we'd covered all the people who were eligible for Medicaid, and that number had gone up because of high unemployment, because of the recession, it would have, and with no new revenue, it would have amounted to about a 39% cut in provider reimbursement rates. That was quite an incentive. So through administrative efficiencies, through making some adjustments to the benefit level, and front-end loading the resources that we had into the first year of our two-year budget, we were able to reduce that cut from 39% down to about 11%. But that still left a $250 million hole in the second year of the biennium, actually $600 million if you count the federal match. And our plan was basically to fill that hole by transforming the Medicaid care model to get more value for each dollar that we spent. So in March of 2012, we passed legislation that outlined how to apply to become a coordinated care organization, and ultimately 16 organizations were formed. And by that time, it was clear that even if we could get significant cost reductions through the new care model, which we believed we couldn't get the system changed fast enough to drive those dollars into the current budget cycle. So in May of 2012, I went to Washington, D.C., and we convinced the Obama administration to give us not only the 1115 waivers to use the coordinated care organizations as our Medicaid delivery model, but also a $1.9 billion 5-year investment. And in exchange, we had to agree to reduce the Medicaid cost trend from 5.4 to 3.4% per person per month by the end of the second year, with no reduction in enrollment and no reduction in benefits, and meeting rigorous outcome and quality metrics. So as we approach the end of the first 5-year waiver, which ends in July of this year, I think it's important to understand why we got that investment and what the expectations were. So we did not get $1.9 billion to prop up the old Medicaid care model during the revenue shortfall of the recession. It was a gradually declining investment, so it gave us bridge funding. It gave us an opportunity to gradually transform that system over 5 years, with the federal investments going down as the cost savings under the coordinated care organizations gradually came up. And that's exactly what happened. All 16 CCOs are meeting all the outcome and quality metrics in the original waiver, and they're all operating at or below the 3.4% growth rate. So because state revenues have been growing at about 4 to 4.5%, and the CCO rate has been about 3.4%, we have netted out in the first 5 years $1.7 billion total fund savings. That's after paying off the $1.9 billion investment. And the estimate is at the end of 10 years, we'll save a total of $8.6 billion in total funds. The reason that's significant is because the Republican proposal is talking about controlling costs through a block grant, which is a fixed global budget that's capped at the program funding level, right, at the program budget level, but doesn't increase with enrollment. So what happens is that over time, as more people come onto the program, the per capita expenditure goes down, which will force states to those cost-shifting mechanisms that we discussed earlier. So what Oregon has demonstrated, that a global budget that's actually capped at the per member per month level rather than the program budget level can result in significant savings without sacrificing quality and outcomes and access. And if, just for argument's sake, every Medicaid program in the country was growing at 5.4% PMPM, and they were to reduce that to 3.4%, the 10-year savings would be about $570 billion in total funds. So there's real money there. There's a different way to get there and control the cost of the Medicaid program without simply doing a meat-axe approach that does ultimately erode access and outcomes and coverage. Now, I understand that most states continue to view their Medicaid challenges. I understand you don't have a problem here in California, at least from the budget standpoint, but most states are facing a pretty significant Medicaid revenue shortfall because of the reduction in the match rate under the ACA and other factors. And it's understandable to look at this as a revenue problem. What I want you to remember is that this is actually, at the end of the day, a cost problem as well. It's not just a revenue problem, it is a cost problem. And the cost component of the problem is not unique to Medicaid. It reflects the cost structure of the overall healthcare system, which means that changes in the delivery system that can reduce delivery system costs will not only save money in Medicaid, it will also save money in Medicare and across the commercial market as well. And to illustrate that, there's a group we formed in 2003 in Oregon called the Oregon Healthcare Quality Corporation, and they released a study in February that looked at cost and utilization across 5 regional commercial markets across the country: Oregon, Utah, Maryland, Minnesota, and St. Louis. And the report showed that while Oregon had very low utilization, we had the highest cost in all 4 of those regions, about 17% above the regional average. And they estimated that if the 2 most expensive regions, Minnesota and Oregon, were to reduce their cost just minimally, 2.5%, about $9 per member per month, it would save $200 million a year for commercial payers. We've got some Oregon-specific data in this study, 143 clinics scattered around the state. The only requirement to be in the study was you had to have at least 600 commercially insured lives. And you can see the top left quadrant is high quality, low cost, and the lower right hand is high cost, low quality. So you can see these clinics are all over the place. And they estimated that if we could move all of these clinics to the average of the 25 top clinics in terms of quality and cost, the savings would be about 11%, or about $2 billion a year across all payers. And this is a huge potential savings. Now, obviously, we have to dig down and look at why some of those clinics are higher cost, because they may have a higher concentration of very sick people. But the example is very, I think, educational. This, we phased in the CCAO care model over 5 years. This chart shows phasing in an 11% reduction in total cost of care, a 5.5% and a 2.75% over a 5-year period. And the chart at the bottom shows the savings that would accrue to Medicaid and to Medicare and to the commercial market. So my point is that we know empirically that there is a lot of room within what we're currently spending to reduce the total cost of care without sacrificing access or quality or outcomes. So the question is, how do we do it, right? How do we take what we learned from changing the care model in Oregon and move our practices and our system towards a high quality, low cost future, and making sure in the process that a significant portion of those savings are gradually reallocated into the community to begin to address the social determinants of health. Now, I didn't bring you the answer today because DJ just gave us 45 minutes. But I want to get this topic of total cost of care on your radar screen, because that is what we need to be solving for. That is where the focus of the national debate should be. That's where we should be applying our ingenuity and our creativity to sort that piece out, because that's the answer, reducing the total cost of care and then beginning to reallocate those resources into the community to address those things that we know have a huge impact on the overall health of the population. The Roman senator Seneca once said that no wind is the right wind if you don't know what port you're sailing for. So what I've just given you is a port, a destination, right, at which I believe all of us would like to arrive, a system that has lower cost and higher quality. Now, I'm going to probably date myself here, but how many of you remember when Jack Kennedy challenged the nation to go to the moon and come back in a decade? A few of you out there, not many. He did that, honest, 1962. When he did that, when he made this historic challenge, he didn't give us a roadmap, he gave us a destination. But by doing that, he changed the focus of the debate from where we want to go to how we're going to get there. And in doing so, he energized and galvanized the passion and the ingenuity and the creativity of a nation. And he gave a speech at Rice University shortly after he made the initial challenge, and I just want to read you a piece of it. "We shall send to the moon 240,000 miles away from the control station in Houston a giant rocket more than 300 feet tall, the length of this football field, made of new metal alloys, some of which have not yet been invented, capable of standing heat and stresses several times more than have ever been experienced, carrying all the equipment needed for propulsion, guidance, control, communications, food, and survival on an untried mission to an unknown celestial body, and then return it safely to Earth, re-entering the atmosphere at speeds of over 25,000 miles per hour, causing heat about half that of the temperature of the sun, and do this and do it right and do it before the end of the decade." We did that. We went to the moon in 8 years. Now, surely, we can shave 6 or 7 points off the total cost of care in the same time period. Let's say 2025. Let's say that's our destination. And the challenge here is not a technological challenge. It is a challenge of political will and a challenge of human compassion. And I believe it is a lot simpler than going to the moon. Thank you.
You do have another slide on there, don't you?
What?
Do you have that? Do you have the social loss ratio slide?
Oh, yeah. You want me to show that slide?
Yeah, put that up there. Yeah, there it
So,
is. Yeah, walk us through. Just, keep going. I mean, you got a little bit about
All right. So the question is, if let's assuming that we can begin to bend down the cost curve, and we've demonstrated in my state that you can do that. 1 million people, 1 out of every 4 Oregonians, is in a coordinated care organization now, operating at or below a inflation rate, a trend rate that is below the growth of state revenues, right? That's very significant. So then how do you begin to move and reallocate those dollars? I think you do it by redefining the medical loss ratio. So we know that the medical loss ratio essentially is the portion of the premium dollar or the healthcare that's spent on claims or healthcare, right? So I think in Oregon it's 85-15 now for the CCOs. So 85% has to be spent on medical claims or in the formal medical system, and 15% can be spent on administration and other things, right? So if you redefine that to I call it a health loss ratio. So a health loss ratio is like that middle slide I showed you from the OECD nations. It counts both medical spending and social spending. So if the medical loss ratio is 85-15, then the health loss ratio is 85-0 because you're not spending any of that money outside the medical system on the social determinants of health. So suppose as a part of the next waiver, we require that each year a portion of the budget be reallocated into the community. So if you start at an 85-0 health loss ratio, the next year you take 5% of that and you have an 85 health loss ratio. So 80% on medical budget, 5% on social determinants. And you gradually increase that at some figure so that at the end of the 5-year period, investments in preventing the adverse childhood experiences and investments in the social determinants of health have become an intentional and integral part of the business model of hospitals and coordinated care organizations rather than simply an afterthought, which it is today. So we're beginning to do that. There's a whole different set of challenges here. What does the delivery mechanism look like to make sure that those dollars are actually going into things that have a good research-based profile for moving the ball forward, and how do you coordinate all the NGOs and different community-based organizations that are out there trying to do this in the same space so that you leverage the dollars to get a really powerful collective social impact. But I think it's possible, and again, I think that the creativity that we have in this nation right now that's being spent on figuring out how to develop new technologies for individuals, even 5% of that on figuring out how we can provide those miracles of medicine at a slower rate of growth, to me is the challenge. And I think one of our speakers this noon talked about it. We're not talking about reducing the cost of medical care. We're talking about reducing the rate at which it grows and getting it down to something. And I think there's more than enough money in the system so that we can provide everything that is meaningful in terms of a health outcome for everybody in this nation.
So I know there's, if you don't measure it, it doesn't matter. Right? It's going to be very hard to spend money on social determinants if we don't measure it.
Yeah, I mean, I think it's true that what you measure is what you focus on, and what you focus on is what's reflected in public policy.
So in the Oregon CCO model, this story is old hat, it's the air conditioner story, but I think it'd be useful here. In the Oregon CCO model, this is relatively straightforward. You can require CCOs to spend money on these social services. It has required some flexible benefit design and some different coding so that different things could be paid for that couldn't be paid for before. Tell us the story of the 5-story walk-up and how that is an example of changing the coding.
The air conditioner story?
Yeah.
Yeah. So, when you talk about Medicare, I know Medicare is not right on the debate today, but whenever you talk about cutting the Medicare budget, there is an incredible political outcry from AARP and just about everybody else, right? It's like the third rail. So this is an illustration of how you can actually reduce that budget while improving quality, lowering costs, and improving outcomes. So assume you have let's say an 85-year-old woman living somewhere in Sacramento, and she's got a well-controlled, well-managed, stable congestive heart failure. She's doing just fine. And she has this little apartment that's not air conditioned. And there's a heat wave in the summer. And the ambient temperature in her apartment goes up enough to put enough strain on her cardiovascular system so that she tips over into full-blown congestive heart failure. So Medicare will pay for an ambulance to take her to the hospital and $50,000 to stabilize her congestive heart failure. What it won't pay for is a $200 window air conditioner, which is all she needed in the first place to stay out of the acute care medical system and in her home. The difference is $49,800 that you just took out of the healthcare system, which didn't affect cost, didn't affect quality, didn't affect outcome, right? And if you multiply that tens of thousands of times, you begin to see that if you begin to look at this problem differently, there are a whole host of things you can do that will dramatically reduce cost and increase quality at the same time.
So can you get to an air conditioner conversation? Can you get to mental health and behavioral health integration? Can you get to this organizational redesign conversation and social spending absent a ER doc in the governor's mansion? I mean, does it take a health policy geek to really dig into the weeds
Beg your
here?
pardon?
I say that with the highest esteem. I aspire to be
You're right.
one.
You're absolutely right.
A geek, that is. I mean, doesn't this take a certain kind of leadership?
It does require a certain kind of leadership. I don't think that it has to be a medical doctor in the governor's office, but it does take leadership. It takes people who are willing to stand back and ask themselves whether the system we have now makes sense. And what we take for granted right now is the overall cost of the healthcare system. And I don't know if you followed the CBO when the national debt ceiling reset at something close to $22 trillion now. That's being driven largely by Medicare and Medicaid. It's the next bubble, right? Mm-hmm. And I do think people are hungry for that conversation, but we're not getting it because this is focused, as Thomas Pynchon said, we're asking the wrong questions.
So Oregon has demonstrated, I think, that it, can live within a per capita capped budget or model. Not everything's perfect yet. They're still figuring it out. There's some politics involved, heaven forbid. But are Democrats in D.C. too knee-jerk on to oppose Medicaid transformation along the lines of a block grant or a per capita model? Or is that an appropriate sort of level of resistance?
Well, I think the kind of block grant that the Republicans were proposing merited a lot of resistance, and the provision that kind of gradually, if you leave Medicaid, you can't come back on except at a dramatically lower rate. I mean, those were political elements that really didn't have anything to do with patient care, right? But I do think that the Democrats should be willing to look at the basic structure of Medicaid. It was created in 1965. It hasn't changed since then. We still have the same FMAP rate, the same way we calculate, and it is mind-numbingly complex if you look at the number of individual categories and the different requirements to be in a category and the administrative cost is. And at the end of the day, these are people. They have different kinds of medical problems, but that program could be dramatically simplified. And I do believe you could propose some kind of PMPM block grant arrangement so that it's not an open-ended growth model, which really it is right now, as long as you also connect that to some requirements for meeting outcome and quality metrics.
So, you know, like many people in the room here, I'm familiar with the health system model in a number of states, 5 or 6. I hold Oregon in very high regard for the transformation and innovation there. Yet, for all of the progress, there are some things that are still problematic, like, you know, we still haven't figured out some hospital pricing there, a way to mitigate that. Still haven't figured out how to manage some pharmaceutical costs. Still haven't figured out a way to, there are some CCOs where certain providers, physicians have majority control and maybe steer things in particular ways. Can you get to the right kind of reform, recognizing this is an incremental process, without taking care of those, you know, the sort of subgroups? Like, you know, putting a cap on top line might be fine, but if you don't also cap, you know, monopoly position providers, it's awfully hard on the system. Yeah, no,
that's you sort of skirted this noon at the conversation. So we've capped the CCOs. Hospitals aren't capped. Pharmaceuticals, medical devices aren't capped, and in a global budget, that will break the bank eventually, right? But it does give you the opportunity then to have that conversation. And this conversation we had in Oregon way back in 1988, and I don't expect any of you to remember this, but the debate was whether we should literally buy 8 transplants for people already on Medicaid, or address some 200,000 people who didn't have Medicaid coverage at all. It's sort of how you make social allocations inside a finite budget. And in Washington State recently, there was a class action lawsuit over one of the Hep C drugs, and the Medicaid program had been covering it, but only for people who had shown some liver damage. And they won the lawsuit, and it said basically that Washington had to provide it for anyone who had the virus, whether they were symptomatic or not. It added $2 billion with the stroke of a pen to their Medicaid budget, right? And where do you think that money is going to come from? It's going to come from investment in low-income housing. It's going to come from investments in social determinants of health. It's going to come from cutting back on prenatal care. So at some point, we have to revisit that. And that's, I think, the question you ask about, you know, you can practice medicine one individual at a time, but you can't create an equitable social policy one individual at a time. So unless you're willing to take on the total cost of care question, you're going to be faced with these sort of almost unanswerable, unponderable moral questions about those kinds of choices. But if you begin to actually recognize that there's a lot of waste in the system, and you begin to have a conversation with how you cap that, and have the pharmaceutical industry, of course, and the medical device industry and the hospitals at the table, but you create that space to have that conversation. I think the way you do it is by demonstrating, in Oregon, for example, what are going to be the consequences of the 1 million people who are covered now if we don't address those issues, right? The whole thing's going to unwind, and millions of people will get damaged.
So in your first Oregon waiver, when you were state Senate president and first-time governor, the Oregon Health Plan, to your point, was facing these allocation questions and came up with an evidence-based prioritized list, which took all of the services that were afforded to a beneficiary and ranked them in order based on the evidence, and then decided you were going to maximize coverage for people and have some limitation of benefits, whereas most states have maximum benefit availability and restrict enrollment as a consequence in the pre-ACA world. But we still don't have a lot of evidence-based medicine, even in advanced states like California. Why do you think the prioritized list model, where evidence would rank all of the benefits and maximize coverage for for people providing benefits that actually had evidence that worked, why have no other states adopted what Oregon adopted in 1992?
But I don't know. I mean, it's pretty transparent. You know, the situation we were facing back then is, even as today, states could control income eligibility even to the categories that were eligible for Medicaid, right? So when we ran out of money, we'd redefine the poor and drop a few people off, as I showed you on that slide up there, and maintain the benefit for other people. So, it's rationing in the sense that we're putting some limits on the services, but it's also rationing if we take someone and say to them, you can't have any services, right? So what we did is our 1115 waiver in 1989 did what the ACA did 20 years later. We expanded Medicaid to everyone with an income below 100% of the federal poverty level. And our view is if you can't afford care, you can't afford care. And then if we ran out of money, we couldn't change the eligibility level, and we couldn't just arbitrarily cut provider reimbursement rates. So we had this priority list, and it was given to an independent actuary that determined the cost of each element. And all the legislature could do was make a resource allocation decision, which by its very nature is political. So everyone stayed covered for at least those things that had the greatest positive impact on their health. And it was pretty crude, the first one we did, but over the years, it's probably worth going online and looking at it. I mean, they figured comorbidities in, if you take this off, what happens up the list, but it became very honest. So for example, if you wanted to come in and mandate in vitro fertilization, which is a really important service for people who are barren, right? I mean, and they can give you a really good story. Before the legislature could add that as a mandate, they had to make the case that it was more important than things that are higher up on the list. So it created a real transparent budgeting process and a real accountability for the legislature.
Well, Governor, I would just say and I know a number of the Oregon Medicaid folks actually think that if nothing else happens in Oregon, that should be copied, or rather if nothing else happens in other states, the thing to copy from Oregon is that prioritized list, because it's relatively straightforward and beneficial. Thank you for coming here. Thank you for making time. Thank you for going to the reception and the bar here in 10 minutes at Scandal Bar, hosted by CCHI. Thank you very much. Let's give them a round of applause.
Great, thank you.